So welcome everybody to a discussion about Medicaid expansion in the HCH community. We're interested today in talking about lessons learned. We've got Virginia and Maine who have made significant progress in expanding and are bringing people online any day now. And so we thought it would be great to have a conversation with folks who have been working in a Medicaid expansion environment for quite some time to talk a little bit about the broad range of changes that you can expect in these emerging Medicaid expansion states. And so today's meeting really is just a recorded call with some leaders in our community just to talk about what's changed for them, what they anticipated might happen but didn't, and then we'll share some advice and some lessons learned so that people who are coming into Medicaid expansion can maximize the experiences of those who have gone before. My name is Barbara DiPietro. I'm the Senior Policy Director here at the Council. I'm moderating today's call, but really excited about hearing from folks who live this every day and can get a really good conversation going. I think there's a lot that we don't often talk about. In fact, I think we've focused so much on outreach and enrollment over the last few years that we haven't really talked a lot about how are we doing with anticipating financing and changes in our clinical environment and what our patients are experiencing. So this is really a great conversation that I'm excited about. And just to give a sense of who all is part of this discussion, from Maryland, we have Kevin Lindemood, who's the President and CEO at the HCH Baltimore there. In New Mexico, we've got Trish Granz, who's the Director of Finance at HCH Albuquerque. In Oregon, we've got Dr. Rachel Solotaroff, the President and CEO of Central City Concern, and Eowyn Reike, a physician who is the Associate Medical Director of Primary Care, also at Central City Concern. So those are our seasoned expansion state folks. And then we've got quite a number of people who are calling in from Maine and Virginia. Marty Sable is the Director of Health Services at Nassau Healthcare in Springvale. Marty's got a number of folks with him, so I'll come back to you, Marty. I know we also have Ann Tucker, who's the CEO of Greater Portland Health, Lori Dwyer, who's the President and CEO of Penobscot Community Health Center in Bangor. And in Virginia, Maureen Neal is the Chief Operating Officer at Daily Planet in Richmond. And Marty and Maureen, I know you've got a number of folks with you. So Marty, why don't I just start with you? Can you introduce the folks that have joined you in the room?
Sure. I'm here with Leanne Kelly, our case manager, and Diane Lorendo, our chief financial officer.
Excellent. Welcome. And Maureen, you've got quite a number of folks who are interested in this as well.
Yes, we do have a lot of people here in Richmond, Virginia, Daily Planet Health Services who are interested in this topic. And much to the chagrin of one of my colleagues, I'm going to briefly turn the camera and show you that there is a number of people here with me. So I will begin by saying Katie Latimer, who is our advancement assistant, Susan Sakurki, who is our advancement coordinator, Beth Merchant, who is our chief executive officer, Keisha Washington, who is our case management services coordinator, Isha Toledo, who is our practice manager, and Helena DeLitt, who is our chief operating officer of programs. So we've got a room full. And
Fantastic.
Stephen, I guess Stephen he's not here in the room with us, he's in another room, but there he is. And he's our medical director, Dr. Stephen Popovich.
Excellent. Thank you all for coming together for this conversation. Really excited about plunging in. Just as a quick context of the world we're working in right now, we still don't have the pervasive Medicaid expansion that we had anticipated at this point. Certainly that was envisioned in the original Affordable Care Act as it was passed. So we've got 34 states who have expanded Medicaid, and we can see here on Kaiser's slide here, Maine and Virginia are that emerging states that are coming online. This fall, we've got 3 more states that have got ballot initiatives that are looking very promising. So we may see 3 more states coming into the Medicaid pool. And then hopefully we'll see more and more of these states turning blue. But we know that there's a significant variance even in the Medicaid expansion world. We know that Medicaid is mostly the insurance that we are working with when we're working with our insured population. We also can see here the disparities between the access to insurance coverage, whether you're in an expansion state or non-expansion state, as a patient in an HCH program. And so as we're hoping to turn more and more of that red uninsured bar into a blue insured bar, we know even in expansion states, enrollment in Medicaid ranges from 92%, which is the high, to 37% insured. So even in Medicaid expansion states, we know that eligibility doesn't necessarily mean enrollment, and enrollment doesn't necessarily mean access to care. So I think as HCH, we're really focused on all of those pieces and really facilitating a robust use of comprehensive health coverage to be able to get our patients range of services that they need, as well as getting paid for the work that we do, which is really great. I know in preparing for this conversation, I had asked for the folks who are coming in from Virginia and Maine to share their concerns about what might happen with this and also their hopes. And one of the things I thought might be helpful in just kickstarting this conversation, some of the things that people expressed concerns about were what the courts might do with Medicaid expansion and how that might thwart ongoing efforts. How will the state, in its Medicaid capacity, handle an increase in backlogs, enrollments? How responsive will state systems be to this? And then how will emerging Medicaid 1115 waivers, which have been used in many states to expand services under Medicaid, particularly in supportive housing and tenancy services, but then those same waiver vehicles are also being used to introduce other barriers to care, so premiums, other kinds of restrictions, fewer services, non-emergency transportation being taken out. Looking certainly at work requirements is the big thing we've been focused on as well. So I think these are some of the unknowns moving forward. But really where people are focused is excitement about getting patients broader access to Medicaid and medications and treatments, more engagement in prevention and wellness activities, which really gets us ahead of that curve, increasing staffing so that we can better manage caseloads and prevent burnout, and then looking at how new state leadership can support expansion and support access and quality of care. And so thinking about how we can achieve all of that moving forward. So I think that's what's kind of on people's minds. At this point, I think that's just to establish a context on where we are. But let's kind of get deeper into our conversation. When I asked all of you who were in seasoned expansion states what the biggest changes were in your world, this list of things really was consistent themes across all of you. And I think what I'd like to start with is the first bullet here, increasing staff, billing activities, and budget. And Kevin, this was something that you specifically talked a lot about in your comments to me. So would you mind spending just a little bit to talk about what that looks like for you in Baltimore?
Sure. I mean, we found that Medicaid expansion had a fairly remarkable demonstrated impact upon the organization. And we had to realize that the billing systems that we had for the organization were pretty anemic, weren't very robust. I see some of you like looking at each other already just upon mentioning that. You know, only about 20% of our clients were Medicaid eligible before. And so we didn't invest a lot in our billing systems. And in fact, we had a moment prior to Medicaid expansion where we had to write off a fairly sizable chunk of money even for that small percentage that were billable. So we really had to look at ourselves hard, tear our systems apart, and rebuild them, rebuild the processes, make sure we had the right people on board. We spent about 2 years getting ready for Medicaid expansion and then went from 30% insured to 90% insured. We've more than doubled over the last 5 years in the number of staff, from 125 to now 270 and growing, all because of Medicaid expansion and some related Affordable Care Act investments, but primarily because we spent the time ahead of time preparing for it, getting ready for that change.
Trish, you had also mentioned this, and I don't know if you wanted to add to what Kevin had said.
We were different. We didn't prepare ahead. It came down pretty quick. What happened in our state was in July of 2013, our governor went after the behavioral health providers in the community and shut down 14 businesses while we knew Medicaid was coming on, but we weren't quite sure what she was going to do. And so we knew we needed to invest in our infrastructure. We went from 78 employees to now we have 108. Our Medicaid revenue went from $70,000 a year to I'm projecting $2 million this year in that time frame. But our state is very different, and we are one of those, because our behavioral health infrastructure was pretty much shut down, we still are facing that in our state. So we weren't quite sure what was going to happen with us. We backed out of billing case management because that's what they went after all of the behavioral health providers for, fraud. And it ends up that most of them were cleared, but it was too late. They already had shut down their businesses. So it was very different here, the idea of Medicaid and what the state could do to you with it.
Got it. I know that increasing staff and billing activities and changes in budget were a really big, it's obviously a big change. Are there others from the expansion states that want to talk a little bit about how that impacted their organization?
If I could, Barbara, just reflecting, underscoring the importance of preparing your billing systems. When we look in Maryland at the other FQHCs that saw their Medicaid percentages go up slightly, about 10%, whereas ours, as I mentioned, went up from 20% to 80%. We faced an existential crisis, so to speak, and really focused us to look at our billing systems. The other FQHCs in Maryland didn't face that same crisis. So though their Medicaid percentage went up a little bit, they still, we saw in the years after Medicaid expansion, had some pretty problematic billing systems. Expansion for them didn't cause them to examine their business model and their billing system to the extent that it did for us. And I think it's meant a real difference between those organizations that have done well post-Medicaid expansion in an expansion state and those FQHCs that are still having financial problems despite increases in Medicaid.
I'm going to second that. I mean, we didn't have billing set up at all in our system, so we had to go back with our vendor and reset everything up. And that took us quite a while to work through how everything was going to work for us. And then, we went from almost no one enrolled in Medicaid to 76% of our clients are enrolled now. And getting them enrolled and having all of that set up, too. But the billing really for us was hiring the right billing people, getting the system set up right. All of that took a huge amount of effort.
And I'm sitting here 4 years later and saying, yeah, all you have to do is rebuild your billing systems. Man, it was a ton of work and a lot of pain and a lot of meetings. But that investment of time and investment in your organization ultimately pays off for the benefit of your clients.
This is Rachel. Can you hear me?
Yes.
Oh, great.
May I ask
the one thing I would add is, can you not hear me? Yeah. So I guess I would just add sort of a little bit of granularity to what we mean by billing systems, because there's the ability to sort of post a charge and collect it, but there's a few sort of process and analytic layers that are worth thinking about. One is thinking about what's billable, what's wrappable, and those can vary state to state. So sort of understanding not just, I know I need to be able to start posting and collecting charges, but what actually is in my rate so that I can submit a wraparound payment for it, and what constitutes a billable service, and then what can you wrap on top of that. And then starting to have, once you're sort of there, figuring out what the financial analytics are that you need to actually monitor performance, around documentation completion and if you do any behavioral health, appropriate submission of treatment plans and things like that. So obviously that's a long game, and you don't want to set those up, but I think as we found that our volume started to increase, when there was a lot of money, you didn't have to have that kind of attention to detail around what's billable, wrappable, and then are you actually sort of following the causal chain of payment appropriately. But if for whatever reasons, the money isn't as, like the volumes aren't as great, and you need to be much tighter with what your resources are, that level of analysis is essential.
This is Tricia. I'm going to say another thing that was kind of shocking for our providers was all of a sudden they had Medicaid telling them that their diagnosis codes didn't match with what they were billing. And that took a long time to get them into a place where they understood that their documentation now mattered a lot more than it had before, and that things were going to get bounced back to them and they would have to address them. That was a really different world for them to have entered.
Could I ask?
We're getting a lot of background noise, and so I just want to be mindful of mute buttons if you're not speaking, but without inhibiting the conversation, but just wanted to draw our attention to that. Sorry, someone was about to say?
Yes, Barbara and Kevin and Trish, I'm very curious about your billing systems prior to, I think Trish, you said you didn't have any, and Kevin, you said you had some, but you really had to look internally deeply about what was going on. Did either of you, do you have internal billing systems, or do you contract with an outside billing service?
That's a very good question. Trish, you go ahead.
We took everything in-house. Since Medicaid really was, at that point, all we were going to bill, we now bill Medicare. And our clients were never going to be billed for anything, and we were certain of that. We took it all in-house. I hired a billing manager. I waited to hire the best person I thought was qualified. That took me quite a while. Prior to having a billing department, I had a staff accountant who would bill, and like I said, it was $70,000 in revenue. It was very easy to stay on top of. It didn't really matter what our practice management system did. Once the volume kicked up, it really mattered what our practice management system did in getting that set up correctly. I think.
Just to echo that, we were on electronic health records, had a practice management system, but we knew our billing operations were nowhere near what they needed to be. We hired an external consultant, a contact through a board member, to come in, look at people, processes, systems, and everyone was telling us we should outsource it, we should migrate to a new system, and this person completed their analysis and sat back and said, in terms of systems, you've got a Ferrari sitting in the garage and someone has lost the owner's manual and you don't know where the key is. Essentially what he was telling us was, your system is good, you're not using it effectively. Your procedures, the internal knowledge, expertise that you need isn't there. So having a kind of disinterested third party who really knows health systems and billing systems come in and give us that analysis was really helpful. Now, we had a 2-year lead. We had 2012 until 2014, so that gave us more time to engage in that activity. But I think in looking back, benefiting from an external consultant saved us in the long run a lot of time, money, and energy. Just helped us direct our efforts a little more laser-like.
Thank you, Kevin.
Rachel, do you? Rachel, do you have anything to add into this conversation? Because I know everyone's billing systems are so different.
I think I said I think I said what I would advise, which was, you know, there's the mechanics of posting charges, but billing is a lot more complicated than that, and particularly as you're trying to really monitor financial performance and do good performance management with your leadership and your managers. So again, that comes a bit later, but I think those are important analytical layers. And to Kevin's point, we couldn't do that without some consultative help.
Got it. One point I'd like to go back to that was briefly mentioned in terms of expanding non-billable services. So certainly the Medicaid eligibility allows you to expand billable services, but along with that, in the model of care that we use, there's a lot of non-billable that comes along with that. Kevin, I know this is something that you had put on your list as something that you have seen. Care to comment about the non-billable services piece?
Sure. I mean, the increases in opportunities to bill for Medicaid, you know, was overnight. We continue to benefit from it, but because we thought very dichotomously that if Medicaid expansion happened, grant opportunities would go down, and that just didn't happen for us. We guessed incorrectly. So because we were no longer subsidizing the doctors, for example, we could use more of our unrestricted resources or grants, foundations and corporations, to fund non-billable services. So we had a single dentist prior to expansion in one location. We've got 4 dentists in 3 different locations today, for example. We invested significantly in our outreach capacity to bring more people into the clinic. Outreach isn't covered by Medicaid. Services in permanent supportive housing. A lot of those, even though we're trying waiver experiments now, generally not covered by Medicaid. But we really took advantage of opportunities to say, okay, what are the range of services our clients need? What's covered by Medicaid and what isn't? And how, in this environment, can we invest resources that previously went to cover now Medicaid-funded services into into services our clients really need that improve their health.
Trish or Rachel, anything to add to the non-billable piece?
Rachel, I would just say that there's, I would reinforce what Kevin said, but also thinking about as you move more towards value-based payment in Medicaid and they're starting to incentivize performance, you have to use some of your margin to then enable that quality to be created. So we started hiring more data people and quality improvement specialists and a population health coordinator, the kind of people who then allow you to achieve the measures and then measure and improve upon the processes that get you to that achievement so that you can then be able to cash in isn't the right word, but then be able to take advantage of some of those value-based incentives. But often then you just want to take the money from those incentives and put them to your bottom line, but you have to reinvest some of the margin that you get from those value-based payments in the machinery that allows you to obtain those quality measures in the first place. And it's hard because those are often the first things to get cut, again, as resources constrain a bit, even with Medicaid expansion, but to be mindful that if you really want to take care of value-based payment in Medicaid or in Medicare, you need to invest in the infrastructure to get there.
Yeah, that's a really important point, Rachel. We in Maryland aren't to the point of value-based care yet, though we're getting there. But so many of our organizations operate with extremely lean administrations, right? And we simply don't have the capacity to analyze data, to have quality staff. Medicaid expansion allows you to build the capacity to do just that. So when we look at our overall budget doubling, our staff size doubling, the percentage of clients that we see didn't quite double. It increased, but it didn't double. And what that's reflective of is a real investment in the stability of the organization, in the salaries of our staff for retention, in all of the things that you need to have a sustainable operation, which it isn't necessarily going to decrease your cost per visit. It isn't necessarily going to increase to that great extent the percentage of people that you're seeing, but it's going to make your organization sustainable for the longer term and allow you to see more people in the future. Investing in your organization when healthcare for the homeless programs aren't used to doing that, we're used to operating really leanly in order to focus more on our clients. You've got the opportunity to really build the capacity of your organization and prepare for all of the future work that Rachel is talking about that comes with continued health reform.
And so in New Mexico, we actually did take a funding cut from our state funding that was for primary care services. They cut us 40% because of the Medicaid. But we have expanded positions. We certainly expanded non-billable with outreach and engagement. And we are now looking this year at that infrastructure, that quality, that data, those initiatives that you have to be able to, if you want to get into values-based, and here it's called purchasing, values-based purchasing, you have to be able to analyze your data. You have to be able to coordinate the care. You have to know who you're serving and the way in which you can serve them the best. And where we're struggling, truthfully, is you get paid from Medicaid from this point, but really your work starts way back here with people, engaging them and getting them to that point. And then because we're a healthcare for the homeless only, at some point we expect to transition them out here, get them housed, get them stabilized. At some point they'll be out of permanent supportive housing into Section 8 housing. And then where do they go in the community? And that's when the cost savings really will start to come for them once we've stabilized them. So really kind of rethinking that whole logic around it is where we're at right now.
One point that had been touched on there, and Rachel, you had put this on your list, is recruiting and retaining staff. As we talk about increasing the staff and the hiring we've done from expansion, curious, Rachel, if you want to talk a little bit about the recruitment and retaining piece that you have experienced.
Sure. The one place, interestingly, where we felt that, it's recruiting providers, I guess, is always difficult. And, we have a booming economy, and so that also just kind of adds to things. But one place in particular is with Medicaid expansion, now payers are very interested in the populations that they used to have no interest in, which are our folks, because these are people that are now really hitting their bottom line and can really affect what their medical loss ratio looks like. So that's all. I don't have any problem with that. It's all well and good. What the payers then start doing is sort of organizing, at least in our community, organizing a lot of care coordination, you can call them hot spotting, other types of teams, and really doing work that is pretty similar to what we had been sort of doing on our own backs in the healthcare for the homeless world. So particularly for sort of master's level, bachelor level mental health and behavioral health clinicians, that became a really hard workforce to hang on to, because finally the payers were saying, wow, that's an incredibly valuable asset in terms of being able to coordinate care and provide behavioral health intervention to some high-cost folks, and they can pay 50% more than we could. I think then also that started with the payers, and then other just in the commercial market, just bigger hospital systems like Kaiser's, and we have Providence out here, our big teaching hospitals started having the same realization. So it's wonderful for those clinicians because they start getting paid what they should be paid, and I hope to someday pay them that. But in the short term, we really saw a hollowing out of our behavioral health workforce.
Trish or Kevin, anything you would want to add about the recruitment, retention of staff?
It's always been pretty hard here to get providers in New Mexico, and we've had a psych mid-level position that's been open for 10 or 11 months at this point. And our chief health officer is having to go back to rethink what it is she's looking for. And I think there is that. I mean, just in our little neighborhood where we are at, 2 different hospital systems have opened clinics within 10 blocks of us since Medicaid expansion happened. So there definitely is a draw to try and get the population.
Prior to, well, there's a couple of ways of answering this question. In general, there are always some types of providers that it's just going to be really hard to recruit, either because of where you're located geographically or because just the nature of the discipline. Psychiatry is, I think, a challenge for just about everybody, whether they're in a hospital setting or a community health center setting, and especially in the community setting where salaries are just exorbitant. But in general, prior to Medicaid expansion, when we did a salary survey, we were at about 10% of the local market, 10th percentile across all of our positions. With Medicaid expansion and the real changes in the business model, we began doing annual salary surveys to market and making investments every year in staff salaries, initially to raise all boats, and then in a very targeted way per discipline to bring people to market. We then hired a professional salary survey company probably at about the 4th year to check our work, see how we were doing, and design a strategy going forward to continue to try to keep ourselves pegged to market. That was something we just didn't have the financial wherewithal to do on a regular basis previously. It was catch and catch can, responding to certain market crises. Oh, the social workers are underpaid this year. The nurses are underpaid this year. With more resources, really, again, this is within that category of investing in your administration, in your infrastructure. You've got the opportunity to think about your people and invest in your people so that you can not only retain them, but you can then recruit really highly qualified people to come to your organization.
In 1 year, we had to move people from 50% of market to 75%. Our psych providers for sure, our medical providers to 75% of market, and that meant people were getting 30% increases. But we had to do it or else we couldn't staff. So you have to get prepared for that as well.
Yeah, and sometimes there are some changes that you do all at once. There are some that you bring staff together and you make a commitment to a multi-year investment. That's what we did with some groups of staff. Look, here's the gap. We can't achieve it in 1 year. Here's what we're going to do. And then that people then saw that you did what you said you were going to do, and so that's been a real retention tool for us. Then the big focus this year is making sure that we're evaluating everyone consistently and now incorporating merit into that conversation. So it's not just market, but merit's a piece of it as well.
We're hoping to get there soon. The other thing we do is for our bottom, we look at the housing wage within Albuquerque, and in January our lowest paid employee will be get $15 an hour. And that was equally as important to us as looking at the provider ranges for recruiting and retraining, because I'm over the front desk. I couldn't keep front desk staff. I'd keep them for like 4 months and then they'd go to one of the managed care organizations or somewhere else. It was just too hard.
Yep. We like Albuquerque have a housing wage based on the local cost of housing, and staying consistent with that is just so very important. It adds, you really have compression within the organization, right? When your salary is, whether it's 15 or 17, you then kind of bump into salaries that are not far from that, and that those increases can't just go on forever and ever. So it really requires a lot of planning, a lot of conversation, a lot of negotiation. But we, like you, have found the investment in those that make the very least, so that they're not, in fact, or at least reducing their risk of homelessness among our staff, just so very important.
I think that was a really good conversation about staff piece, and I think that there is so much there. We could have a whole separate conversation just on that, so we might even put a pin in that and do future conversations. I want to switch topics a little bit and move to a clinical issue, connecting patients to specialty care, hepatitis C virus treatment, other treatments. Rachel, just since you started actually the expansion in your clinical role and are now in the CEO role, curious if you just want to talk a little bit about what it meant to connect more patients to care. I know we've talked a little bit about increasing referral staff and stuff like that. From a clinical perspective, what's your observations and what this means?
It's better. You know, trying to get a Medicaid patient into orthopedics, for instance, though, is still an 18 to 24-month enterprise. Just some specialties are more apt to take your patients more readily. That could be because of supply. It could also be because they just like to be choosy. So, you know, cardiology and pulmonology and kind of your bread and butter specialties, particularly your non-surgical specialties, are much easier to access. Things like orthopedics and neurosurgery, though, that's not happening. You know, that's still a 12 to 18 month wait. And even our community has tried to set up a number of systems with e-consults, so at least you could try to communicate electronically with sort of a central bank of consultants, so that if you just wanted to get some advice while you're waiting for your patient to be seen, that's been an innovation to help smooth that over. So what that leads you to, though, is particularly if you have you know, an academic partnership with an institution, like all of our physicians are they're from Oregon Health and Science University. It leads you then to think, okay, how much of this can I bring in-house? So we now do, for instance, almost all of our own Hep C treatment because we have the providers who know how to do it, and we have good connections to specialists who can help us if we get in a bind. That's a whole sort of the reimbursement around Hep C is a whole different fascinating conversation. But I think again, so just bullet points, that access to specialists improves. It improves even more when you have access to electronic consults. Surgical specialties are still really hard to access, and so the amount of any of this that you can bring in-house is really to your benefit. We actually, for something like wound care, which particularly in a healthcare for the homeless environment is so acute and can be really, you know, can be really advanced, it was just too hard to send folks back and forth to the wound care clinic. So we just invested in one of our providers who had a real interest in it. She's a PA, and she became a certified wound care specialist. So again, the opportunities to do this, because also now you can pay for it, to do some of this in-house and provide better care, I think are numerous.
Kevin, Trish, anything you want to add to that?
I think Rachel answered it extremely well. I mean, I think in every community there are going to be and particularly in rural communities, limits in specialty services, but those are patterns that generally a wider array of health providers experience. So it's kind of a community-wide problem to solve. You know, in our case, with the majority of our clients uninsured prior to expansion, the only specialty care we could leverage was through hospital partnerships or practice partnerships where services were provided pro bono, and that led to long wait times, or some people getting specialty services and some people not. We saw that change virtually overnight with health improving and even life-saving results that were pretty powerful to behold at the time. I mean, I remember this 3, 4, 5 month window where it was just an eye-opening experience to actually have the ability to, in a generally timely fashion, refer people for specialty services.
Yeah, the change was great. I agree with everything that they've said. And we have one provider who was really excited, and we've started a Hep C clinic, and he loves working it. So that was a big opening for something that one of our providers was really enthusiastic about. So, but the referral, it really has opened up a lot. I think the surgery ones are the hardest ones.
In the interest of time, let's just move forward. I know we didn't get a chance to talk to everything, but I know we've got a lot of other issues that we want to cover. I know we had talked about grants would decrease as billing increases, and that I think is varying across sites. But there's two things here about demand for care would eventually decrease and enrollments would eventually decrease, and that those were things that had been expected but hadn't yet been realized. And curious, Kevin, Trish, Rachel, did either one of you, any of you want to talk about what that decrease, did that happen for you? Did it not happen for you? Or enrollment still going strong and steady? What's been your experience there?
I lost the connect through the picture thing. You may be able to see me still, I don't know. For us, enrollment has now become something that we track. I have a report in my system that I run every month that tells me who was billed sliding fee this month, who previously was billed Medicaid, so we can see if people are falling off and then contact them and work with them to get enrolled.
This is Rachel. I would, sorry, I like to talk into the phone. There is, I think, I don't know if we're going to get to this later. It's the same. It's more to the competition, but we've seen some flattening of enrollments, and I do think that's because there's just more players in the market. And so what that pushes us to do, it's not a bad thing, is say, okay, how can we be better? You know, how can we do things, to Trish's point, like add Hep C treatment, add our wound care clinic, add, integrated medication-assisted treatment, all the things where people say, wow, this is the, I kind of have some options of where I can go, particularly whatever we can do around connections to housing and employment services and case management. So it's sort of fun to not just hang out the shingle and wait for people to come, to kind of be actually really actively understanding and responding to not just client need but market demand. But it's a new chunk of work. It's always the right thing, but go ahead, Kevin.
Exactly, and it's pretty exciting to design a system that actually not just is good for those that we're serving, but that is just a part of providing good whole person health care. We've not yet experienced the kind of competition that we had feared, though much like you were saying, Rachel, other groups are certainly paying attention to the population that we serve a little bit more. Our enrollments are still going fairly steady. We've incorporated our enrollment work into the organization, but the growth in our patients, our patient volume, which for 4 or 5 years in a row was just increasing steadily, 10% year over year, has begun to level off. So we had a lot of staff investment to increase access to services, and now we're at the point where we're saying, okay, this is our new size, and it's really forcing us to look at things like quality, patient volumes, utilization, all of those tricky questions that can make us better at our current size. But decreases are no longer masked by rapid increase in new patients year over year. So it makes your system limitations visible again after that initial couple-year impact of Medicaid expansion begins to normalize. Does that make sense?
Hi, this is Marty. Can I ask a question? So with your new size and your increased revenues, are you making changes in terms of your expectations for provider productivity? For example, are you lengthening the encounter time periods, or are providers having more time with the patients?
You try not to use the P word, Marty. The P word is very much a four-letter word, and no. We've been looking at it in terms of client access. What is client access to the organization? And because of those system investments that Rachel and I and others were talking about, we now are getting to the point where both our process data and our outcomes data is pretty clean. Actually gives us good information. So we're able to look at utilization and what the utilization is, and we have been able to navigate through various providers in the organization to come up with targets for what our capacity should be. What is in a healthcare for the homeless setting, look, it's not going to be every 15 minutes, but what is the reasonable expectation for medical providers, behavioral health providers, addiction counselors, supportive housing staff, baking that into the schedule, what does that look like, and then measuring utilization. Okay, this team is at 50% utilization. You're telling me you need a new provider. At 50% utilization? Probably not. If we get that up to more like 80% utilization, okay, let's look at what additional capacity would be. So it's given us the ability to develop the tools and the data to really navigate those conversations and make more informed budgetary and staff size decisions. But yes, and in a grants-based organization, you're not focusing as much on productivity, right? You're focusing on what do our clients need to get better. And so suddenly you make that transformation into an organization that's billing for the large majority of your clients, and you're facing the same kind of volume conversations that more traditional FQHCs have faced for a very long time.
The only tactical thing I would add to that is that in periods where we've had a big influx in patients all at once, like a smaller clinic around the corner from us closed and transitioned, hundreds of patients to us over the course of several months, we've just hired clinical staff, usually a nurse, just on contract, just to do chart abstraction and just try to get relevant information into the EHR, because those are the sorts of things that are really crushing to providers. And we can see patients, but when you're trying to intake multiple new patients in a day, getting your head around and inputting all that information is really a barrier. So that's something, if you're maintaining the steady productivity stream, but also taking on a lot of new patients, that can really make your providers and your teams happy.
In the interest of time, we'll keep going. We can come back to some of these issues. Let's talk a little bit about the questions that had come from folks in Maine and Virginia. And you weren't the only one who asked about how have state Medicaid programs responded to the increase. Have they? And I think there's been a lot of questions kind of around that piece on what kind of partner the state has been in this expansion. And again, Medicaid varies widely state to state, so everyone's experience is going to be different. But curious, Kevin, do you want to start about how Medicaid in Maryland has responded to the expansion?
Sure, and I'm interested in this conversation, particularly with you, Trish, because I think from what I know of Albuquerque, it happened in a different way, and really points toward the importance of your state either embracing expansion and really working to make it to capture as many people as possible and bring them into the system, or really kind of slow walking the entire thing and having greater gatekeepers and limiting access. So Maryland made the decision to pre-enroll tens of thousands of people in the state who were in an old indigent care program. So they were not Medicaid eligible, and yet they proved income eligibility for this other program, and the state pre-enrolled all of those individuals into Medicaid. So they would tell us, look guys, January 1st we're going to flip the switch and everyone's going to be in Medicaid, and we said, yeah, sure, right, we've heard that before, and they actually did it. They did an incredible amount of advanced work, and overnight our percentages went from 30% insured to 90% insured. That was because of the way the state went about doing it, aggressively pursuing Medicaid expansion from the very beginning. We since have a different political party, but Maryland is kind of a blue state with a Republican governor, and Medicaid has still been kept pretty whole, and the state works on getting people enrolled as quickly as possible. So we've had a good partner in our state Medicaid agency. Now looking at other ways to expand further, like through creative pilots, adult dental pilot that we're starting, a supportive housing pilot. So we've built upon those relationships with our state Medicaid agencies to try to do even more.
New Mexico.
I would imagine, Trish, your experience was different, right?
We were a little different. They said they would have people enrolled. They really didn't. Our ID budget that first year more than tripled because we had to help people get IDs. And we've kept it at that since then. They were allowing people, they would go back as much as a year to back because they were so slow, the rollout of it. It was a guarantee like 6 months before you would find out whether or not someone was in it or not, because they didn't have the infrastructure, they didn't have the software set up, they didn't have anything set up. They made the decision and then announced it, and then 6 months later thought, hey, we're going to go live with this, and it was a mess. It's straightened out a lot. There's still some issues with people who are incarcerated and coming out of incarceration and getting them re-enrolled. They're being told two different things, but when you look at the waiver that this governor submitted that has not been approved, our plan always included dental. They're now looking at dental as a value-added thing, like skin in the game. They want the ability to pull it out. They want to charge premiums to anybody over 100% of poverty every month, and they say that they'll have they'll put a process in place for homelessness, but no one knows what that is. There's a lot of other things in the waiver. The fact the waiver hasn't been approved by CMS in 9 months could be a good thing, could just mean they're slow. We're not quite sure what. So this state was very different in how it approached it. It was not at all prepared. It didn't have any of the infrastructure, didn't have any of the system. We have managed to get paid, but that's because we stayed on top of every penny that was out there and just kept going after it and going after it and going after it. So I think it really, a lot of it depends on how prepared your state is and how they've set up their systems.
And I would say whether you're in a state that is embracing expansion or a little reluctantly moving forward with expansion, just underscore the importance of finding ways of getting involved with your state Medicaid agencies. Most states require citizen advisory boards or committees. You can either work politically to make it happen or nominate yourself or a member of your organization to be involved in groups like that. Most states have stakeholder groups moving forward some of these changes. It's an opportunity to get your staff and your clients involved in that work. And then I think as healthcare for the homeless providers, you've got a pretty politically popular issue here that historically has crossed both sides of the aisle. And that is expanding care to the most vulnerable members of our community, to people experiencing homelessness. Leverage that. Invite policymakers to your clinic. Hold meetings post-expansion praising them for their work, because that then gives you the relationships necessary to also be critical of their work if you need to advocate a different approach to expansion. But I tell you, people love to come to an event where you're going to share data about people that had absolutely no access to care before, that now because of their work have this kind of access. And I would just encourage you to use those opportunities to put your organization in front of policymakers and to join stakeholder processes so that you can your voice can be heard and you can leverage additional change.
One of the things our state did is they made it mandatory for the managed care organizations that regardless of whether we had a contract with them or not, if we billed, they had to pay us. So it prevented that, well, you've always provided these services, why do you want to be paid now? We're just not going to negotiate a contract with you. And it did happen with some, but the language is in it that they had to pay us regardless of whether our contract was signed or not. And I can tell you, I had an OSV in June of 2014, and I still didn't have 2 out of 4 signed contracts with the managed care organizations. And that was one of my unmets at that point with them. But they were still paying us because they had to. So you want to make sure that there's something like that in there, especially if you're negotiating with the MCOs, because it's not in their best interest to pay you.
One other quick bit of advice is this may happen in Maine and Virginia, but the way that Medicaid expansion was deployed in Oregon was with the development of what are called CCOs, or coordinated care organizations, and they're kind of like ACOs. In fact, they're the same thing, but they're just called CCOs because, I don't know, it's Oregon. But there was sort of this idea of a coalition of providers coming together to form the payment mechanism that would, administer all these new Medicaid dollars. And the MCOs were a part of that, but it became a larger enterprise because, again, they're really, because of the focus of there's a focus in ACA with value-based payment and global payment and that kind of thing. So my boss, my predecessor, Ed Blackburn, was very intentional early on about making lots of relationships with the CEOs of the hospitals, so that as our local CCO was forming, they realized what a critical thought partner he was in caring for a highly vulnerable population, and placed him as a founding board member on our CCO. And what that ultimately led to was obviously a greater understanding of healthcare's involvement in housing and investment in housing, bricks and sticks, and that kind of thing. But I would, in addition, I think Kevin's advice about having, political folks come to your shop is a great idea, but also starting to rub elbows really with hospital partners so that if a new payer entity is formed, you as a healthcare for the homeless provider can really have a seat at the table, literally at the board level.
I know there's a lot to pursue here. I want to, just in the interest of time, move on. And I know, Maureen, this is a particular interest of yours. How do I talk with my private funders about ongoing needs? And I think this was something we talked a lot about in coming up into Medicaid expansion is if you get, now that your clients are insured, why do you need, these other funds? And Kevin, I know this is something that you had said was a concern that didn't come to pass, but any tips that the three of you might have for the emerging states about ongoing need for non-Medicaid dollars?
I'm the finance person. It costs us what we get paid versus what it costs us per encounter is probably 2.5 times what we get paid. So that was really easy. Like, it costs us this much. This is what we're getting paid. And in our instance, the amount we were being paid didn't have anything to do with us at all. So it was very easy to point to that. And then so much of what we do is not Medicaid eligible at all, you know. So I think that's how the development people talk.
Our total budgetary pie changed a lot over the past 5 years. You know, initially skewing from just a tiny percent third-party billing to a very large percent of the budget. Now it's only about 40%, and about another 40% is federal, state, and local grants. We took the approach, especially with private funders, of being incredibly transparent. During that period prior to expansion, we brought them together. We showed them our books. We had to write off about $1.5 million because of those really bad billing systems that I mentioned. We showed our largest private funder what that was, talked to them about it, said that if we're going to benefit as an organization from Medicaid expansion, we have to make this investment in our infrastructure now, and we want your partnership to do it. And that large foundation brought 3 or 4 other foundations together, and they made a multi-year investment in our infrastructure, both billing systems, data capacity, and so forth. Then Medicaid expansion happened the way it happened. We were prepared for it. We were able to go back and show those funders what their investment resulted in. Wow, did that become transformative to our relationship? Because now they say, look, you were transparent with us. You did what you said you were going to do. Look at what's happening now and how many people you're serving and serving more effectively. What can we do now? Right? So those same funders are investing in our dental capacity and in our outreach and in our supportive housing work because they were partners in preparing for expansion and making that most beneficial to those that we're serving.
Rachel, anything to add in?
No, that was very complete.
I know we've got some more questions here. We're going to try to end at the top of the hour here. I want to just fast forward. We'll come back to a couple questions that you might still have outstanding, but let's just talk about advice. So Kevin, Trish, and Rachel, if there's one piece of advice here that you would want to advance here, since we're speed dating in the last 10 minutes or so of our time, Kevin, what's one piece that you would want to offer to the conversation?
I remember being on the phone with Bob Taub, who ran the Boston Healthcare for the Homeless program at the time. Massachusetts had expanded Medicaid way ahead of time. And he, in a very circumspect way, those of you who know Bob Taub, he said, Kevin, don't underestimate the potential of Medicaid expansion. And it seemed like really simple advice at the time, but those words continue to ring in my ears over the last 5 years as we've seen the result of that. It can really transform your organization, your business model, those you serve, and it's a combination of preparing for it and navigating that new environment with your staff and with all of your partners going forward. And you know, I'm so excited hearing about what Rachel is now doing that I think the groundwork here in Maryland, we will get to that point where we're really talking more about value and how hospitals and health systems can invest in things like housing and so forth.
Excellent. Rachel, I know you've got to get off soon, so what's your piece of advice that you'd want to put into this discussion?
I think all of these are really great points. think I tossed in number 5. There's going to be a lot of shiny new objects coming out. You know, everything from whatever the pain points in your community are. When Medicaid expansion was happening here, our opioid prescribing, it really hadn't tipped over to heroin as much yet, but the opioid prescribing. So there were just endless initiatives around opioid prescribing and get this case manager. And every HCH patient had 7 different care coordinators attached to him or her, because every hospital and ER and payer and clinic had their own, you know, hot spotter. So just be, the advice I put here is really think deeply about what are the real needs of my population and where do we really have expertise. And as a lot of these innovations and, you know, funding opportunities pop up, try to just, at least in the early stages, stick to what stick to those areas of strength, particularly given all the other operational considerations that have been brought up this hour.
Trish?
Look ahead to values-based, because we didn't, and we don't have panels of clients, which is now going to create a huge problem for us as we move into values-based, because if they're not assigned to us, how do we know we're improving anything? So really pay attention to how you get your clients impaneled to you.
We have covered so many topics, and I know that we skipped fairly quickly over a lot of content and some of your questions. And so at this point, Maureen, you've got a lot of folks together with you, and Marty the same. What questions would you like to use our last few minutes to answer? And I'm sorry, and Ann and Lori, I know you're also out there too.
I guess our big one is in the expansion states, do you have concerns about HRSA's possibly withdrawing some of your federal funding in recognizing your increased revenues from patient services? Has that come up in discussions with your project officers or anybody at HRSA?
Oh.
What we've heard is it's this one and done. I don't know, Kevin and Trish, but this idea of, hey, you don't have 19 requirements anymore. Actually, it's 91. And if you have one, if you miss one, then you have, I forget what one and done stands for, but it's a little bit of death by 1,000 cuts. You know, I think our need to now increase our compliance, scrutiny, and vigilance of the policy manual is much greater. So I don't think they're explicitly saying we're going to pull your funding, but they're really, really, really raising the bar in terms of compliance and then right to remedy.
I would agree with that entirely. They're lifting the bar for everyone and not exempting healthcare for the homeless projects from the broader community health center mix. But you know, prior to expansion, general community health centers in Maryland had a pretty high, about 75% of their clients were insured, a little higher than that, almost the exact opposite of what ours was. Now our insurance rate, insured uninsured rate, pretty much mirrors other community health centers. So I'm not all that concerned about that changing, particularly if you're an organization that then invests in unfunded services and continues to provide access for those that are uninsured. But would agree that the stakes are higher in terms of compliance, which kind of circles back to our earlier point about investing in your organizations and making sure you have quality and compliance staff, for example. We never had that before in our organization, and now have an entire team that's doing our quality and compliance work.
I think that's the same with us. It's the compliance part. The one is done is you get one unmet. They come back the next year. They only give you a 1-year award instead of a 3. They come back the next year. If they find anything, and it can be any other thing than the one that they did, they give you 1 more year to fix it. And then if you don't, and they find more stuff, you're done. You don't get your funding at all. It's not a percentage, it's all gone. So that's what one and done is. So compliance is incredibly important.
Stephen, it looks like you've got a couple of questions about staffing.
Yeah, for those, can I just ask a follow-up question to Trish's? I'm wondering if anyone that knows about HRSA nationally doing those compliance standards, about like how many organizations like have lost their funding? Like what is the actual risk?
I'm on the administrator's call and committee, and most of the people who've had a recent audit have done really well on it. So it seems, and I say this, and it seems as if they've kind of relaxed a little when they come and do the operational site visit, and it shifted it somewhat. But I don't know, really and truly. It just is a general sense that we're feeling.
Thanks, that's helpful. Yeah, I think our, of course, we're in Richmond, Virginia, Daily Planet Health Services. I think two of the things that really ring true to us is the need to think a little more closely about our quality program and also looking more closely at our billing capacity. And I'm wondering if folks that had done this could make a recommendation about like, hey, what are first steps for an organization that like at this moment doesn't have any dedicated staff in those areas?
Hire someone? Seriously, I mean, we have, and we're a small healthcare for the homeless. I mean, we serve about 45 to 5,000 people in our UDS, and we have 3 compliance positions under us now, and that's been a change over the last few years. And like I said, we bill about $2 million, and I have 3 billers and a business systems manager who's over front desk and the billing. And I needed that to get all of that done. So really looking at what your volume is and hiring people that understand quality and compliance.
Other questions that might be out there from Virginia and Maine that we didn't get a chance to ask related to the Medicaid expansion?
Oh yeah. Have any of you had an experience where the people who are eligible for Medicaid don't want to sign up for Medicaid or refuse to sign up for Medicaid and enroll?
Outside the realm of my experience, no. I mean, has there been a person or two that we've been trying to engage in the outreach setting who is saying no, not right now? Maybe, but no, generally I find that people are excited to be enrolled and have health insurance.
Yeah, I mean, maybe there's 1 or 2. I don't know that there's been many. The funny thing is when a client says, now I can go anywhere. And you're like, yes, you can. You can go anywhere.
Come here.
Yeah.
Yeah, and when the client chooses to stay with us, and I think that's really what we talk about, our quality of care and the model and meeting people's needs. I know we've talked frequently about this idea of competition for patients, and curiously, at the end of the day, other providers, even with a Medicaid payment, aren't interested in clients that have got 10 and 12 different conditions all wrapped up together. But our clients, even if they do choose another provider, our experience has been that they come back because they weren't treated well, they don't have cultural competencies in other more traditional settings. And our clients are very faithful to us in many ways, and I think that's been really helpful.
You know, it occurred to me as we've been talking about all of this, and you know, I mentioned that it can sound kind of cavalier to take a 5-year period and truncate it over the last hour and say, yeah, we did this. There was a lot of trauma individual and organizational compressed in that. Think about all the changes we're talking about. Incredible organizational change, not only for administrators, but for clinicians and clients. At the same time that I think we all acknowledge we're in a pretty uncertain external environment, which is also filled with a lot of change. Here we are, expanding Medicaid, you're hiring me, but I'm hearing that the president is going to cut Medicaid and undo Obamacare, and what is that going to do to me? All of this points toward the need to really think about change management and how you institutionalize lasting change and involve people in it. With respect to the external environment, my biggest advice is to try to find a way to turn off the volume and work with the opportunities you have in your community and take advantage of Medicaid expansion. I think history will tell us that will withstand political fluctuations over time.
Wow. I think that is a great way to close out this conversation today. Thank you, Kevin. Just as put up a number of resources that we've developed over the years, most of this aimed at frontline workers who are doing enrollment and outreach work. We've also done a number of policy briefs and webinars over the years that look at some of the changes too. So we will make sure that you have all of this. And at that, we will talk, this is not the only conversation that we will have about Medicaid expansion, and we're hoping to have more and more people coming into the Medicaid expansion pool where this is an ongoing conversation. And I don't discount that this might make a really good conference workshop or a discussion at the conference on how we can be sharing this lessons learned and advice and making sure that others can learn from the mistakes that we made along the way. So with that, I will say thank you to everyone for participating. We'll close out this conversation now, and we'll note that there will be more conversations to come in the future. So at this point, thank you so much. And